Great. Excellent. Well, thank you all for all of these excellent presentations and lectures today. I believe that we are ready to start the questions and answer session. I appreciate your time and your efforts. So we are going to spend at least the next 18 minutes just answering some of the questions that the audience have for us. Actually, the first question for David. Thank you so much for participating in this symposium. But there is one important aspect of clinical work and research. Do you mind emphasizing what is the importance of all of this research that we are putting together for understanding acute flaccid myelitis, and the importance of doing research in the middle of a major critical illness like AFM? Do you mind expanding on this?
Well, Carlos, I appreciate the opportunity to. I think the testimony to it is listening to the other presentations from earlier in the afternoon. The amount of information that we've learned so far is really impressive, and kudos to people working under difficult situations to make that happen. We've learned an awful lot. What we've learned then in turn shows how much more we have left to learn, how much farther we have to go. And the hope is that the anticipation is that by building out this biorepository, data repository, and image repository, we will make it easier. It will streamline the opportunity for subsequent research to be undertaken. And it can do so because things will have been gathered across 38 study centers prospectively, and each person, each site doesn't have to then go in and try to recreate it themselves when they've got a new study idea, a new research hypothesis. And as we all know, everyone involved with this webinar today, both on the speaker side as well as the audience side, it's really that opportunity to push forward, push ahead in our knowledge of things that really gives us the opportunity to impact patients' lives and families' lives.
Thank you, David, for that explanation. There is a question for our three pediatric neurologists here. I consider myself a pediatric neurologist too. But the question for all of you, three of you, is there is a lot of concerns among families about what is going on with COVID-19 and what is going on with children that have been already affected by AFM and the risk of COVID-19. Do you mind sharing with us your counseling recommendation that you are giving to your patients in each of the institutions that you are working? Beth, you are first.
Sure. So thank you for asking that important question. And it's certainly in our patients' minds. I think all of us that are participating here see patients with a number of neuroimmunologic conditions, and we follow, I don't think I mentioned, but we have a long-term follow-up program for our AFM families, so in patients. So people are reaching out and they're asking the questions you would expect. Should I come into the hospital? Should I do something different? Should my behavior be different than other children? And the bottom line is we don't know. It's a rare condition. I would say that I personally have not seen any new issues in my patients, and that's nice. We are still learning so much about COVID-19 and the inflammatory conditions that are associated with it that I think it would be really early to speculate. I think many of us wonder there are similar questions about why, when most children do fine, do some children have a serious neurologic condition as a result of an infection? So there are overlapping questions there that I don't think we have the answers to yet. So personally, I'm advising the same strategies that Maryland, we're still under stay-at-home orders, and so it's fairly easy to comply. I think where things will get tricky is down the road when there are different behavior options, how we advise our patients and families.
Thank you, Beth. Leslie.
I agree with everything Beth said, and I think it's really hard. I mean, fortunately, I haven't come across any of my AFM patients who have had COVID, so we don't have really any experience to speak from, and I haven't heard a lot of experience. I do worry the most, I need two thoughts. One, plenty of my AFM patients experience recrudescence of their weakness in the setting of illness, and so it wouldn't surprise me if we see some recrudescence in the setting of COVID. But with resolution of the illness and fighting that off, which they've done, I hope that they would be able to do as they have with other URI type infections. I'm not particularly worried per se about that. I do worry more about the kids with the diaphragm or intercostal weakness or the scoliosis, not about their lungs themselves, but those who may have an increased chance of being compromised from a respiratory standpoint if they got the infection. Like Beth said, we really don't know, and that's all speculative.
Sarah?
I would echo what both Dr. Wells and Dr. Benson said. I think there are some questions about it, but we have also been lucky. I don't know that any of our patients have had it. I would be concerned about the couple of patients that we have that are still on ventilators, and we have advised those families to be very careful. But otherwise, I'm hoping that we're not expecting, other than it, as Leslie mentioned, maybe some recrudescence, any significant issues fighting off the infection. Kind of loosely related, other neuroimmunologic condition, for neuroimmunology in general, there is some better data about multiple sclerosis, which is of course a different illness, but does sometimes also affect your spinal cord. And so for those patients, even those that are on sometimes immunosuppressants, there really doesn't seem to be much of an increased risk with the coronavirus. So just some interesting data there, I think.
Thank you very much, Sarah. David, I'm going to put $1 million question for you. So everybody's running and rushing to get a vaccine, and families are very anxious about what is going to happen with a pediatric population that is going to be at risk and vaccines. And for our patient with AFM, the question is, should we vaccinate these patients for flu, for COVID-19 when the vaccines are available?
Yes. So let me explain a little bit more. Would you expect me to say no, Charlotte? Right now, in the midst of this pandemic, this worst health crisis we've had in a century, we are seeing as a comorbidity, if you will, of that, significant declines in the usual childhood immunizations, and that is putting a lot of children at risk for a measles epidemic on top of a SARS-CoV-2 pandemic, which would be a real travesty. If the advances we've made at polio eradication or at measles control, if those are lost, we're in bad shape. So generally speaking, we need to double down on immunizations, on vaccinations, in the midst of this pandemic. And I've seen some encouraging data that show that that's beginning to happen. Just before, I missed some of the first parts of the presentations today because I was on a call with the American Academy of Pediatrics and the Centers for Disease Control and Prevention about COVID-19 vaccines. And of course, we're real early in that process and the timeline for development of that, although it looks pretty encouraging right now. I think we've got a lot of bumps in the road ahead, likely, but I'm glad that at least we're as far along as we are. We began. A question I had for the CDC was who would get the vaccine. Who would? By definition, we're going to have limited supplies to begin with. Do we start with children? And I think the answer was probably not. We don't know yet. The decisions are not made, but most likely to be first responders that would be vaccinated first, and then high risk or higher risk adults or people around those adults. And then eventually we're going to back our way into the pediatric population, and we'll have some safety data in children as well as some immunobridging data, assuming we find an immunologic correlate of protection. so that we'll have more understanding of what to do in pediatrics. So children, when it comes to a COVID vaccine, I think are going to be on the back end. Most likely, I'm guessing, will be on the back end. And we'll have a much better idea of how to do it in a patient such as a patient with AFM. And then, of course, with influenza, anytime you can protect yourself against a disease like flu, you should, especially if you already might have some residual compromise from AFM.
Thank you, David. Alwyn, your presentation was quite magnificent with all of the illustrations that you gave to us, but there are several questions from the audience. One of them is, when there is gray matter and white matter abnormalities, and there is the diagnosis of a combined transient myelitis and acute flaccid myelitis, if that makes sense? In other words, are the two disorders able to coexist? And the second question that I have for you is about atrophy. When there is spinal cord atrophy, is that because the gray matter or the white matter? And do you mind explaining a little bit to the audience about that?
Sure. So the first question about the AFM versus TM, I would consider AFM to be a distinct kind of disorder, and it's really characterized by gray matter predominant abnormalities on the MRI. I think it's clear from seeing a lot of these patients that in some cases the white matter can be involved as well as the gray matter, but the primary abnormality is within the gray matter, and white matter involvement appears to be surrounding that, rather than, for example, having areas of white matter abnormality without gray matter abnormality. So I think that's what really defines the radiological picture of AFM and often makes it distinct to cases of TM or transverse myelitis. Is really just a sort of a broad term used for patients who have inflammation of the spinal cord from a variety of different disorders. That can be infection, inflammation, multiple sclerosis, neuromyelitis optica, MOG antibody myelitis. They all sort of fall within the basket terminology of TM. So I think what we should overall be trying to do is be more specific in our diagnoses rather than giving a broad term like TM, try and narrow it down to whether that is felt to be due to an infection, inflammation, or in this patient group in particular due to AFM, a distinct sort of subpopulation. And the second question was regarding atrophy. So yeah, in some cases we do see a little bit of atrophy of the spinal cord after AFM, and I think they tend to be cases where there is really prominent residual lesions present in the anterior horn cells. I think one of the questions was, what is the cause of that residual lesion? Is that from gray matter atrophy or demyelination? The gray matter does contain some myelin in the spinal cord, but the myelin fibers are primarily situated in the white matter surrounding it. So I think when we see those lesions of really bright T2 hyperintensity in the gray matter, what we're seeing is probably destruction of some of the anterior horn cells in that region, and sort of gliotic change left over after that inflammatory process has abated. So I think it's primarily a gray matter rather than a myelin-based process.
Thank you, Alwyn. And this question actually is for Sarah and for Beth, and this is in reference to a concept that has been very prevalent even in the 20th century. And other things. And it's the decision about getting MRIs with sedation. Any particular comment about that decision, and any particular comment about the need for sedation of patients that may need MRI, because that is going to involve another major element like drug. Comment about that, Sarah first, and then Beth.
Sorry. So we've just been having quite a few discussions about whether or not we want to adjust the way we do this for our AFM protocol this year. Basically, yes, that is a concern. Anytime you have someone with bulbar dysfunction, trouble swallowing, cranial nerve abnormalities, neck weakness, you are worried, or respiratory muscle weakness, you're worried that if you give them a sedative and relax those muscles further, that yes, they're going to require intubation for that reason. And for that reason, we don't use sedation in these patients. We would go to full general anesthesia for those patients to eliminate that problem, and also to eliminate the problem with aspiration that you can sometimes have with sedation without a better airway placement. If we're where the neurologist has gone in, has seen the patient, and they feel like we can get a very focused image of the spinal cord, say just the C-spine, protocol that with the neuroradiologist, and maybe do a shorter study to see if we can avoid the sedation, we will do that. It's not always possible, but we'll try to minimize at the very least the first study if we can do that to try to get an answer.
Thank you, Sarah. Beth?
Yeah, I agree. I think we're still taking it case by case. So where some of what we do is quite tightly protocoled, the anesthesia approach, we have guardrails, but then, approach each patient. But certainly trying to put safety first, thinking about how we are looking at the lumbar puncture and the MRI together, but ultimately aiming to get the best diagnosis. The other component that we look at is the timing. So I think we mentioned that sometimes the initial MRI is normal, and so the need for a follow-up assessment. So making sure that we get that second MRI at the right window, because if you are going to sedate someone a second time or use anesthesia, you need to make sure that you're not doing it on the wrong day. And so we've had that discussion where some kids who've rapidly improved beautifully after a few days with the normal MRI, but really needed that follow-up MRI to make the diagnosis, to make sure, that we did it at, for instance, 7 days rather than, 3 weeks later.
Thank you so much. Very brief question with brief answers. Leslie and Alwyn, is there any need to have a follow-up MRI after a patient with acute flaccid myelitis?
I think it's a little bit uncertain at the moment. I think based on work that the Japanese group has done and our group in Hopkins, there is some evidence that the follow-up MRI may have much more prognostic information in it than the acute MRI. Since the acute MRI is dominated by swelling, you don't really get to see the areas of the spinal cord that have been preferentially affected. So with the follow-up study, you do get to see where the residual lesions are left behind. So that may correlate with where the patient's weakness is. And I think just a practical consideration as well is that many of these patients have a long lifetime ahead of them with potential other problems emerging over time, or may have some deterioration or something happen at some point later in the future. So I think even from the point of having a new baseline for what a patient's spinal cord looks like after an event such as this is possibly useful. So certainly in the adult population, it is something that we would do unreservedly. We would definitely do a follow-up MRI. Obviously, when you're dealing with children, you have to consider sedation. That brings another element into it. But I think it may have some clinical utility, but to be seen, I guess, in further research studies.
Thank you. Leslie, what do you do in Boston?
We've talked about this before, Carlos. I don't re-image everybody. I take it on a case-by-case basis. And some of them, yes, I do. If there's worry for new symptoms, if there's uncertainty about the diagnosis, I definitely found them helpful on a case-by-case basis. But there's also a lot of very little kids who need sedation, who are already sort of compromised, and I don't do it for everybody.
Thank you, Leslie. Beth, your last message for the audience in the ER, pediatricians, pediatric neurologists.
I think these days it's really safety assurance to go to the ER if you have, to encourage our patients to come to the ER if they have these symptoms. People are afraid, they're delaying, they're seeking alternative routes. They're maybe going to a more subacute facility first before presenting to a major hospital ER. And I think we want to get the message out that we're all taking a lot of precautions to make it a safe place to take care of patients.
Thank you, Beth. David, the last message for our audience.
Anything I want to talk about? I think that, again, I think we should celebrate what we know, but we also have to recognize what we don't know. I mean, even something as basic as to whether this is a viral process or a post-viral process, and how that, the downstream consequences of that therapeutically are amazing. And then the other thing I'd say is, as you can tell by the collection of speakers that Carlos and his group have put together here, this is a not only national effort, but an international effort to take what is a rare condition and to rapidly learn as much as we can. And so I think we should also celebrate that collaborative aspect of how far we've come, but also how far we have yet to go. And we're going to go farther together.
Thank you, David. Leslie, the last message for our audience today.
Just want pediatricians and ER doctors to think about AFM. Just know it's out there and we want to catch it early.
Great. Sarah?
I'm going to echo both Beth and Leslie. It's much safer if your child is developing weakness to come into the emergency room than it is to stay home, no matter what the cause of that weakness is ultimately. And, asking first-line providers to really keep an eye out for that. It's tough because COVID is at the forefront of everybody's minds, and then it happens once every 2 years, and it's not there in a high prevalence all the time. So really just reminding people to keep it in their differential.
Thank you, Sarah. Alwyn, the last message for our audience in Europe, United States, Canada, and
just one thought from the imaging perspective is that, the abnormalities in AFM are subtle and particularly sometimes in the early phase. And I think the SRNA is doing a great job at trying to put together this physician portal, so that if people encounter cases that they suspect are AFM, and they may have never seen a case before, the radiologist may never have seen a case before, having the imaging reviewed by somebody in another center who has more expertise may really help in narrowing the diagnosis.
Thank you so much, Alwyn. Well, thank you all of you for being available this afternoon. It's great to hear your experience about research and clinical work. And thank you to all the participants and the audience around the world that were very ready to complete this marathon of almost 4 hours of acute flaccid myelitis information. And it's great to see the number of people that are still participating in the meeting. And we appreciate your perseverance and patience here. And we will wait for you next week when we are going to be talking about acute flaccid myelitis and the critical care management. And again, just register, make sure that you have everything set up. And sorry for the glitches today with the computer, the communication. Make sure that you use the best option in terms of web internet connection. And again, next Friday at 1 o'clock, we are going to be discussing more AFM. And thank you all of you, and enjoy your weekend. Thank you very much.